It gives me great pleasure to present Dr. Marianne McLaughlin. She is a physician scientist who's focused her career on the development of clinical programs and clinical research to improve cardiovascular care in vulnerable populations. Dr. McLaughlin is associate professor at Mount Sinai, and she's received $1 million of funding with the National Institute of Health, as well as the CDC and the Agency for Healthcare Quality and Research. She is an exemplar clinician and researcher who has developed programs to care for those who are at increased risk of cardiovascular disease. And Dr. McLaughlin has double duty with us today. She is presenting a two-part talk on just really the common things that we really have to think about in older adults around cardiovascular disease. Dr. McLaughlin, thank you for being here today.
Oh, it's my pleasure, Helen. It really is a pleasure to be here. So, as Helen so nicely described, we're going to be talking about several different topics that are all very important for your patients as they age. And if I talk too fast near the end, that happens. You'll be able to read the slides if I miss any, but I plan on not missing anything. I have nothing to disclose, no conflicts of interest. And the first talk I'm going to give today is starting out with hypertension. Very important in our older patients, coronary artery disease, statins, and then if we have time, we'll talk a little bit about aspirin. So the question is, in an older individual with hypertension, how low do we go? That's one of the questions. How many medications should a patient take, et cetera? So the first thing when we see a patient with hypertension, don't forget, even if they're older and we say, yes, hypertension happens with age alone, please don't forget to rule out the other reversible causes of hypertension. So renal vascular disease or narrowing of the renal arteries can end up with worsening kidney failure. Patients can come in with history of atherosclerosis. That's a risk factor. When you're doing your physical exam, you listen for abdominal bruits. I've actually picked them up and found renal artery stenosis. So importantly, the treatment now is if there's a narrowing in the renal artery, we can put a stent in. We can balloon it and put a stent in and cure them of their hypertension. Number two, primary aldosteronism. So if you see patients with low potassium and they're not, especially if they're not on a diuretic, please think about checking for primary aldosteronism because that can be corrected as well. Thirdly, obstructive sleep apnea. So I would say, in my office, at least once a day, I diagnose someone or tell them to get diagnosed for sleep apnea because they snore and they're overweight, et cetera. It's something that has now been listed with the American Heart Association as the 6th risk factor for coronary artery disease is untreated sleep apnea. So patients who come in and they're tired, their blood pressure is high, they don't sleep so well, especially you ask them if they snore. If they don't know, you talk about doing a test. So that's important. The next is drug or alcohol-induced hypertension. So those people who have a couple glasses of wine every evening think it's no big deal. They've been doing it for years, but the alcohol can be one of the risk factors for developing hypertension. Other things to think about, those people who are taking NSAIDs like all the time, or COX-2 inhibitors, or amphetamines. So people who are taking amphetamines for their ADD, they're on steroids, or they're taking some supplements. So ephedra, Mawong, those are supplements you just talk about. Those could be causing the hypertension. Cushing syndrome with elevated steroids. Usually the people are gaining some weight. They have sometimes they can get stria marks because they've gained weight in a short period of time. So not to forget about Cushing syndrome, it's treatable. Pheochromocytoma, I have diagnosed in patients coming in with palpitations and very high blood pressure. And you look at their epinephrine levels and they see that they're high. You can look at your adrenal glands. We definitely can diagnose people, and then that's treatable. So important. common variations with happens in our older population that you probably have all seen is that some people come in with a higher pulse pressure, right? So their systolic is high and their diastolic is much lower than you expect. So that is a variation. You still want to treat that hypertensive systolic level. Also, there is when most of us go to sleep, our blood pressure should drop. There's a normal dropping in that. And some people really don't feel well with their hypertension, and it could be that they're hypertensive all the time, 24 hours. And if that's a suspicion, that's an indication that we do a 24-hour ambulatory blood pressure monitor. We have them here at Mount Sinai. You put them on in the morning, the patient goes home, wears it overnight, and brings it back. And then we can actually change the way we administer the timing of the medication. So that's important. Another thing I see every day in my office is orthostatic hypotension. So I have a lot of patients coming in saying they're feeling a little lightheaded or a little dizzy. Sometimes it's after they've been walking, sometimes just in general. And so it's important, and hopefully most of you do some orthostatic hypotension, orthostatic blood pressure readings in your office to be able to detect this and then treat it, right? So you want to avoid things like diuretics. You want to maybe give them some leg compression stockings to get that blood return back up to their brain a little bit faster. You want to make them careful about changing position quickly, et cetera, and not over treating their blood pressure, their sitting blood pressure, because when they stand up, they're going to fall. It's important. And then I see this at least once or twice a year where a family member comes in and says, our mother was at dinner and she really stood up and didn't feel well. And I just said, what did she eat? What was the meal? And it's totally postprandial hypotension where there's a shift of blood going towards the gut to enable the digestive system. And then the blood pressure falls. So it's something to think about. Okay. Pathophysiology, I mentioned briefly, but it's all related to increased stiffening of the arteries. So there's reduced elastin with age. There's increase in collagen and calcium depositions in the arterial media. So the stiff arteries end up leading to isolated systolic hypertension. It's much more common. So the elevated systolic blood pressure level, but they have a low to normal diastolic level. We call it systolic hypertension and we treat it. There was a big study called the SHEP trial, and that showed that we should treat that to prevent risks of stroke or cardiac disease. Those who do have this systolic hypertension have a threefold increase in MI, myocardial infarction, left ventricular hypertrophy, renal dysfunction, stroke, and even cardiovascular death. Another thing that we think about from a physiologic perspective is flow-mediated arterial dilatation. It's really mediated by your endothelium and the nitric oxide, and so that can decline with age. And in some people, their neurohormonal profile also is reduced, so the plasma norepinephrine is increased, the renin levels can go down, and aldosterone levels can go down as we age. This is a busy slide that I've shown before, but just a couple important things. And looking at the center picture, you have increase in arterial stiffness, which has increase in pulse wave velocity, and aortic impedance and LV afterload wall tension is reduced. So the aortic root size can get big. You have aortic wall thickness. You can have, this is where it causes the increase, we just mentioned, increase in the systolic blood pressure. Coronary blood flow can be diminished, leading to myocardial ischemia. Remember, with hypertension comes increase in LV wall thickness, impaired relaxation, and then that ends up with a diastolic heart failure. So this is, all physiologic with aging for most individuals. So what's normal for our blood pressure? So the normal, every year they start talking about changing the numbers, but less than 120/80. In older patients, we become more flexible and let those blood pressures go up a little bit higher. But by the books, we would say if the patient's between 130 and 139, or the diastolic's between 80 to 89, that's considered stage 1 of hypertension, and that's in all adults. Stage 2 is when the systolic is greater than 140, or again, the diastolic is greater than 90. It's important that we treat these measurements to get down to normal blood pressures. These are just the guidelines to show that the recommendations are to treat those patients who have confirmed hypertension. And even if they don't have all the other risk factors, a target less than 130/80, it may be reasonable, right? If you have an older patient who has dementia and falling and other things, then you can relax those requirements a little bit. It's all about looking at the individual patient as well. So again, isolated systolic hypertension, the coronary artery disease risk varies directly with systolic and pulse pressure, and inversely with diastolic pressure. There's worse outcomes in the elderly with the low diastolic pressures. Not that you're going to necessarily change that too much, but it's important to know. Okay. So the diastolic blood pressure should be greater than 65 in someone with coronary disease, greater than 60 in patients without CAD. And the theory is like you don't want to overtreat with too much of an ARB or an ACE inhibitor and have their diastolics go too low. Okay, so it's important if you can. So again, treatment of hypertension with a systolic blood pressure goal of less than 130/80. And again, there's the caveat. It's recommended for people who are non-institutionalized community dwellers with an average blood pressure that's higher. So if someone has severe dementia and they're in an institution, you're not going to need to really get their blood pressure to such a low level. In the other patients, importantly, cardiovascular events were reduced by 30% and all-cause mortality by nearly 25% when high-risk patients were treated to a target blood pressure of 120 versus 140. Now that's pretty low, but these are the really otherwise healthy people who are in the older age category, but don't have many other risk factors. So you could go as low as the 120. That was all the SPRINT trial. And then importantly, how do we treat blood pressure in addition to medications? Importantly, weight loss, healthy diet for those who are overweight. Those who are overweight, and you can, by impacting their weight, you can actually lower their systolic readings. The DASH diet, I always want to talk about this. It was the largest study of dietary ways to reduce blood pressure, and was very effective. So the patients were given all their meals for several weeks at a time. They were the DASH diet is rich in fruits and vegetables and whole grains with reduced content of saturated fat and total fat. If you Google DASH diet recipes, you can get all the recipes. So the DASH diet is now considered one of the healthiest, heart-healthiest diets. So I refer everyone to look at those recipes and incorporate them into their healthy diets. Reduce sodium when possible, and potassium. Aerobic exercise can reduce blood pressure, isometric exercises, and by reducing the alcohol consumption, right? So reduce alcohol. Men should drink, I think this is a little sexist, but they say less than 2 drinks per day, but women less than 1 drink per day can lower the blood pressure 4 millimeters of mercury. So those are important things to tell your patients to do at home. Increase their aerobic activity, and they can drop their systolic blood pressure reading by 5 to 8 milligrams per mercury, right? So millimeters of mercury. So it's very important. Sodium restriction, again, The tone trial was studied looking at this, where they really said most people eat 4 grams of salt a day. But if we restrict it to 2 grams, which is a teaspoon of salt, and avoiding of all of those pre-made lunches and dinners, then you can actually really lower the blood pressure and maybe get off medications. It's an important thing that patients usually want to get off their medications, right? So that's something to tell them. And so when you're prescribing medications, you want to start low and go slow. The baroreceptor function declines with aging, so you don't want to drop that blood pressure too fast. Most people in the older age group will require more than one medication, and often we do the combination of 2 different blood pressure medications to reduce the side effects of each of them. And so the common grouping we have: calcium antagonists, diuretics, and then the ACE or ARBs. Those are the 3 sort of general categories. Beta blockers are also used more in people who have coronary artery disease or arrhythmias. So if someone has atrial fibrillation and you want to keep their heart rate lower, then a beta blocker is a very good first line for them. It's usually considered second line unless there's that indication for a heart rate. There we go, compelling indications. Okay. Okay, so remember, as we age, by age 70, particularly, the prevalence of hypertension is very high. It's usually characterized by elevated systolic blood pressure with a normal to low diastolic. Still have to treat the systolic. It's an important risk factor for cardiovascular disease, heart attack, stroke. So it's very important. And so even with people, say, 60 to 79 years old, many studies have shown reductions in bad outcomes with drug treatment. Okay, so in general, when we do look community-wide, blood pressure control rates remain suboptimal in the elderly. Remember, in the office, I always check the blood pressure at least twice. The first one's always usually going to be the highest reading. I do it a second time, and if there's a big discord, then I do a third time, and always have them stand up and do the orthostatic, because you want to treat to that standing blood pressure so they don't feel faint or they don't faint. Okay. First, remember to encourage the lifestyle changes in diet and aerobic health. That really aerobic activity helps lower blood pressure. And then, yes, initiation should start always with the lowest dose and go up slowly in our older patients, for sure. All right, so now we're switching gears to coronary disease, right? So if we have untreated hypertension and dyslipidemia, diabetes, we're going to have an increased risk of coronary artery disease. So the risk factors. All right, I just went through this list. I forgot to add renal disease. So diabetes, hypertension, hyperlipidemia, renal dysfunction, and smoking. Biologically, what's happening is there's an increase in oxidative stress and then endothelial dysfunction, leading to, the vascular compliance is not as good, right? So it's like a rubber hose becomes a stiff hose, right? And so that increases the risk of coronary disease in hypertension as well. Also, remember, in this age group, the symptoms may be less typical. So we always have pictures of a middle-aged man clutching their chest like this. This is the Levine sign of angina. It doesn't necessarily happen that way. I remember seeing a patient in the ER not long ago, and he came in and he said he just felt really weak and he felt a little short of breath and he couldn't walk as far. And I said, "What did you think was happening?" And he said, "I think I was having a heart problem." I said, "Well, why did you wait 24 hours to come in?" Right? Because deep down, he knew that there was something brewing that was really not well. So we have to take those hints and do the evaluation. And we want to look at what is the severity of the coronary disease, what are the comorbidities that we can treat, talk to patients who have dementia, right? We will want to keep their carotid arteries healthy so they don't get more vascular dementia. All right. So we look at the guideline-directed medical therapy, adherence, bioavailability, and drug interactions, right? Those are the things we have to think about when we're making the choices. There can be bleeding complications when we're treating people with coronary disease with aspirin or other antiplatelet medications when they have a stent or percutaneous coronary intervention. Bypass surgery, coronary artery bypass surgery. There can be some ischemic limb complications if the blood flow, you take out a saphenous vein and you can have some edema in that leg for sure, bleeding complications. So now we have a lot of different options. We start with medical therapy, and then if we can do just minor interventions with stents, we can do that very easily these days. So what else? We're going to talk about other risk factors. We talked about the main risk factors, and then the biological. This is the summary of all the things to think about. Is the endothelial dysfunction, oxidative stress. It can be genomics and epigenetics can influence patients in their older age with their risk for coronary disease. So this is showing just from the molecular level, the mitochondrial oxidative stress can increase. There can be the genomic instability, epigenetic changes, all of these leading towards cardiovascular aging with cardiac disease. When we look at the differences in epidemiologic changes, so in men, we see, going up, starting at the ages of, 55 to 64, there's already some symptomatic coronary disease. And similar trends in patients. This was the study, the cardiovascular health study, showing that, again, there's a linear correlation with aging and symptomatic coronary disease. So let's see. In the younger age groups, if you look from males versus females or men versus women, the prevalence is higher in the men. 65 to 89 years old. And that's cardiac heart disease. But when talking about myocardial infarction, it's also very similar, but it's also higher in Blacks compared to white individuals. So it's important as we age, that risk of myocardial infarction increases. It can be with symptoms of just shortness of breath and fatigue. So you have to really be thorough in asking what the patient is feeling. The angina may be slightly higher. More women will come in with the angina, but not necessarily the heart attack. Older patients actually tend to present more with left main disease or multivessel disease, right? So the younger patients, usually they'll have like one blockage and they get treated. But once you see someone in their 80s, they're likely to have 3-vessel disease. And with that comes left ventricular dysfunction often. So that your evaluation should always look at what their functional capacity has been, what their cognition is like, and what their frailty is when you're choosing the medications. Because as you all know, that it becomes a little more complicated to balance multiple medications. Let's see. So next we go to, yes. These are just the challenges that we see in our practice every day, right? So sometimes they do have this vague nausea. I forgot that nausea, shortness of breath. You have to think about the heart. Sometimes, we can't, they're frail and they have limited exercise capacity. So when we make the diagnosis, we now have better ways. It used to be all about the stress test and putting people on treadmill, right? So we still do that. So we do stress echocardiogram. So we do the echocardiogram, put them on the treadmill, do another echocardiogram. importantly, for people who are not able to walk on a treadmill very well or quickly, that's not a great test for them. Importantly, because when they have to get off the table, off to the treadmill to get down to do that second echo, if they can't get down quickly enough, then it's a waste of the trial, because then the heart rate goes back to normal, right? You want to do it whether heart rate is high. So a nuclear stress test is important. You can do it with a walking exercise nuclear test, or a pharmacologic test where they inject the medication that is a vasodilator, and then they take pictures with a nuclear tracer at rest and then after the injection. So that can help for people who really can't ambulate and do stress imaging. And importantly, we now have the coronary CT angiograms, or CTAs, where it's a CAT scan with IV contrast like we do with other CAT scans, but looking right in the coronary arteries. And it's like going to the cardiac cath lab. We can see all the arteries beautifully. Maybe there's a couple areas that might be not as crisp, but that gives a diagnosis of coronary disease without needing the exercise portion. Okay, I'm including these visuals because of the boards. So I know in the past on the geriatric boards, there were questions about, acute coronary syndromes or myocardial infarction. So unstable angio is considered an acute coronary syndrome, as well as the MI, and as well as this, of course, this is the ST elevation MI that you don't want to miss in your practice. Coming in with chest pain, it's usually a plaque rupture, right? When you get this ST elevation, you've had cholesterol plaque, and then the patient does something exercise-wise or emotionally wise, and the plaque ruptures. And then it causes the thrombosis, and the whole artery gets blocked. So that's the one thing. So that's the ST elevation. Then you have the non-ST elevation, where there's a demand ischemia. So like they are fine when they're sitting, but they have this blockage that's maybe 60, 70%. And when they get up and try to run upstairs for something, they require more oxygenation. And then that triggers that cholesterol plaque to break. So you can get some MI, or you can get some unstable angina. Okay. So 35% of the MIs occur in people over the age of 75. It's higher and more in men than women, even over 80. The non-ST elevation is more common as we age. It's the younger people with the vulnerable plaques that are not haven't solidified that are more risk. Remember, I've seen this over and over again. People come in with just shortness of breath and nausea, and they just look pale. They don't look right. They say something's not right. And you do the EKG and you do the troponins, and you find that they're having an event, or they're at really high risk. So remember, the silent unrecognized infarctions can account for 1/3 of the MIs, especially in older patients. And remember, patients with diabetes sometimes don't have the same pain response, so they might be missed as well. The EKG is always going to be a little bit more tricky in an older patient because they get left ventricular hypertrophy. So sometimes it's a little tricky, and then you need to do the stress test or the echo. So factors contributing to this acute coronary syndromes. This is the summary slide. So it's the endothelium, it's the hemostatic syndrome system. It's all of the risk factors. All right, so we're not going to go over this. This is the incidence of death within 1 year by age. So 65 to 79-year-old, the risk of dying from a heart attack, and this is a non-ST elevation heart attack, is 13%. But by the time you get to over 85, 33 to 45% risk of mortality, right? So within 1 year, very important marker there. You need to treat them. And this slide is just a complex, but listing all the things that we just summary of the risk factors and the treatment considerations in the older patients, right? The guideline directed medical therapy first, then they come in with an event, they need a stent, or they need bypass surgery. Aspirin, they give acutely. This is a board type of question. 2 baby aspirins or a full dose aspirin, and then they get an aspirin for life. Beta blockers immediately and at discharge, ACE inhibitors, aldosterone inhibition if patients have a lower ejection fraction. And if reperfusion therapy, we think about giving them thrombolysis if they're not near a hospital that has a cath lab, if they're especially then live in a remote area. And then there's a primary that, or you just go right to the cath lab if you have a cath lab and put a stent in directly. And we do that every day here at Mount Sinai for sure. This is another like a board question, maybe not for your boards, but internal medicine definitely has this on their boards, like primary PCI should be performed within 12 hours of symptom onset, with 90. So once the patient has symptoms, within those 12 hours, you have to get them from their car to the emergent to the PCI. It's 90 minutes from door to balloon time, we call it. And so if someone's coming into the ER door and they're coming in with chest pain, you really need to activate the cardiac cath lab. You activate them 24 hours, 7 days a week, get the right people in the room and open up those arteries. Fibrinolysis, if there's no one available to do a stent, that we can still do that, streptokinase, like we did before we went to the cath lab so often. So let's see, if the patients are older, you really don't want to get thrombolysis unless you're making sure that they don't have cerebral artery disease or that they've had a TIA or something. So you don't want them to bleed. If there's a risk, you don't want them to bleed in their head for sure. The contraindications, I know these are on different sets of boards, like that's why I keep it here. So anyone who's had a prior intracranial hemorrhage, or you know that they have a cerebral vascular lesion in their brain, or they've had a malignancy in their brain, or they've had a stroke within the past 3 months, or you think that they have a suspected aortic dissection or active bleeding. This is not in the older woman, but younger women, or they had a closed head trauma. So this definitely is on the medicine boards. It's on the cardiology boards. That's why I stick it up here. I'm not sure it'll be on your boards, but those are things that, just to know about. And then these are the relative contraindications, so like recent surgery within 3 weeks and peptic ulcer disease, use of anticoagulants. Those are the things that are going to be a higher risk for giving them fibrinolysis. And so I've had patients, in their 80s get bypass surgery and do very well and live to 99. As we age, the risk gets a little bit is higher. Female gender seems to have a higher risk in the operating room. Having a recent myocardial infarction within 30 days is a risk factor, or having a low ejection fraction. So if the heart function is really reduced, that's going to be a higher risk for bypass surgery. And then all of the comorbidities, especially the renal insufficiency, going through surgery is definitely not going to help that. Having a left main or 3 vessel disease is also a higher risk. I'm not going to go through this. This is what the surgeons use in order to choose, again, and the cardiologist, which is a patient going to the stenting or surgery. And then another kind of score we talk about, and we're doing some research here about it's whether their walking score, their gait speed, can predict mortality or major morbidity. And here are people who have normal gait speed, and their probability of a bad event is still quite low. But as the people are really slow walkers, really cannot get their gaits taking much longer, that's a risk factor. So that's something we're looking at in our aortic valve group here. So again, mortality or major morbidity according to gait speed, and the surgical scoring, mortality goes up in the patients who have slow gait speed. So this is a normal gait speed, this is slow gait speed, and this is very slow. So the risk is something important to talk about and look at in your office when you're trying to plan future therapies or surgeries or procedures for your patients with cardiac disease. So for this summary, we have morbidity, mortality rates increase with age. PCI and CABG, so stenting and bypass surgery, improves symptoms and quality of life in many elderly patients with chronic symptomatic coronary disease. We are able to do this now, like if instead of doing a full-on open heart surgery and bypassing 3 vessels, some people are doing just the LEMA, like the left internal mammary artery bypass, and then doing stents in the other arteries, right? So that reduces the surgery time and complication rates. So when patients are frail, and we need to talk to them honestly about their risk and benefit, that's what we do. Talk about that. So a couple more slides. Yeah, no, we had some time still. Statin therapy. Okay, this is important, right? So does everyone benefit from statin therapy? No. Once treated, should statin therapy be withdrawn? Possibly. If there are side effects, muscle aches, and if patients are leaning towards end of life, trying to get off of medications that are not changing their blood pressure or other things, then statin withdrawal is another option. The US PSTF guidelines have said that statins are preferable and are important in patients 40 to 75 years of age with one or more risk factors, including dyslipidemia, diabetes, hypertension, and smoking, or if their 10-year risk of having an event is 10% or greater, right? Not everyone needs a statin for sure. So you have to look at their other risks and their other life choices, right? So if we look at individuals 60 to 79, 69% of men and 67% of women have some combination of coronary heart disease, hypertension, which is very common, stroke, heart failure, combination. For those who are over 80, they're more likely to have cardiovascular disease due to stroke or heart disease. Average age of the first heart attack is 71 in women, 65 in men. So it's very common. And so should we try to put more people on stents to prevent, right, MI and stroke? The Jupiter study showed a reduction in all-cause mortality with primary prevention and with reducing stroke in patients who had never had an event before. And then the HOPE-3 also showed a reduction in events. So the number of patients greater than 80 in these studies was modest. So the benefit for patients greater than or equal to 80 is expected based on the bell curve in patients that are 70 years old and seeing consistent improvement. But again, it becomes just a life choice of, there's no specific evidence in people over 80. So if people are trying to cut down on certain medications, and improve maybe their quality of life, but not their longevity, it would be reasonable to stop the statin after 80. Let's see. So let's skip that one. So lipid management. Oh my gosh, there are more than statins in the wheelhouse of what we use to treat elevated cholesterol, right? So we have the statins, which can reduce LDL 25 to 50%. It can have some benefit for HDL. It can lower triglycerides. The ezetimibe or Zetia, sometimes we add it to a statin if patients are getting muscle aches with statins. Ezetimibe does not have the side effect of muscle aches, and it can lower total cholesterol 13% and LDL. It's a nice 18% decline. So combination of a low dose statin and ezetimibe is very effective. The bile acid sequestrants, they might be harder. Those are for people who really can't take other things, but they can cause some more GI distress. Fibrates are also very good. And so these are old guidelines. So, but again, in adults 75 years of age or older with an LDL between 70 and 189, they're saying a moderate intensity statin is reasonable. So again, we don't want to be ageist. We treat all comers, even in patients over 75. But it's reasonable to stop it if they have some functional decline. There's heading towards a nursing home. Their cognition is not so great. Their physical ability to enjoy life is reduced. Then some people do end up stopping the statin therapy with that in mind. And so again, when we look at the primary prevention in the elderly, the studies support primary prevention with statins in up to range 79, but the data after 80 is sparse. So it really depends. We have 90-year-olds who are, walking up mountains. So, in my office, so I wouldn't withhold it necessarily for those who are still very healthy and active. But we have to be careful about the altered pharmacokinetics and pharmacodynamics. Then there's the impacts of polypharmacy, frailty, cognitive decline, and sometimes we take away medications. This one they say is limited time. If you're an older patient, you might only have 4 to 5 years left to benefit from them, but that's okay. It can still reduce stroke, right? So we can't just think about heart attacks all the time. Stroke reduction, so important. So again, definitely reasonable to give to patients in the older age, shared decision-making like we always practice, and talking to the patient and asking what their goals of care are. And that's just a duplicate of what we just talked about. Okay. A summary, right? So secondary atherosclerotic cardiovascular disease prevention. So that's someone who's already had a heart attack, unstable angina, or a stent, right? We know that statins will benefit that group with event rates and mortality. Severe hypercholesterolemia. So if someone comes in with a very strong family history, they're making way too much. So they're making LDLs greater than 190. Someone who has diabetes, even in the age groups of 40 to 75, and an LDL that's over 70 to 189. Diabetes is a strong risk factor for heart attack and stroke, so we say that that's reasonable. Primary prevention over the lifespan, it's they don't have diabetes, but we use a score called the ASCVD risk score. And if that is elevated, then it's reasonable to keep the statins going. Okay. So if you're not sure what to do with your particular patient, these are other risk factors that can move you in one direction or the other, right? So they have a family history of premature atherosclerotic cardiovascular disease. They have an elevated lifetime risk. There is a really high risk of having an event. Their LDL greater than 160, or C-reactive protein. We do that very commonly in our offices. C-reactive protein greater than 2 is an increased risk of inflammation and events. A calcium score, a total calcium score greater than 300, or an ankle brachial index that's diminished. So people who have claudication and they get studied and they have disease of their peripheral arteries, that's definitely important to know and to treat. And again, we say it's always a discussion, as you all know, between your patients and yourself. And then there's these really, really nice tables the American Heart Association puts out too about high intensity statin, what that means. Atorvastatin 40 milligrams or 80 milligrams, and rosuvastatin 20. So if someone just came into the hospital with chest pain and they had a 90% blockage in their LED and they got a stent, they need to be on a high intensity dose of a statin. Moderate intensity for those, these are the numbers: atorvastatin 10, rosuvastatin 5 or 10. Like you can give moderate and low intensity for more of like a primary prevention. You can give the pravastatin 10 to 20, lifmastatin 20, or fluvastatin 20. All right, so should we withdraw things at age 75? Again, there's a study in France, and they found that those in that group, previously they had taken it for at least 2 years. And when they did stop it, they had an increased admission rate for a cardiovascular event. So, you know, it's all about goals of care in the older than 75-year-old, but if they're very healthy and doing well, and then they could clearly stay on it. What do we do about triglycerides? So didn't talk about them much at all. So some people are taking fish oil, which can help. The strength study didn't show omega-3 really helped reduce event rates, but there are some physiological benefits. And so I'm stopping here because we're only a little bit of time. So the aspirin dilemma is, what to do with stable coronary disease, right? So in general, if patients have had a heart attack, a stent, bypass surgery, then we still recommend, if not a low dose aspirin, because it can irritate their stomach, then we can think about using alternatives such as Plavix, right? So Plavix is a potent antiplatelet, clopidogrel, I use the generic, but it doesn't cause stomach side effects. I think skipping through this because